Hello, everyone. Thank you all so much for joining us this evening for our Tennis and Golfer's Elbow webinar hosted by Dr. Matthew Hernandez. I'm Olivia with Ethos Integrative Medicine. I'll be moderating this webinar. Before we start, please remember to mute your microphones, and if you have any questions, feel free to type them into the chat. We'll be sure to answer them at the end. If you have specific questions pertaining to your personal care, we cannot address that in our webinar tonight, but I highly recommend scheduling a free 15-minute consultation with Dr. Matt. He'll be able to answer your questions and help you to navigate treatment options. And I will go over more information about this at the end, so stay tuned. I'd like to start off our webinar by introducing our regenerative orthopedics expert and men's hormone specialist, Dr. Matthew Hernandez. He believes that when patients live pain-free, they are able to live their life to the fullest. His key to success is combining a comprehensive plan, cutting-edge image-guided treatments, and collaboration with other providers to get patients the best care possible and help them live an active lifestyle pain-free. Today, he'll be diving into what tennis and golfer's elbow is, how it develops, and how regenerative medicine can improve pain and repair the tendon without surgery. So we're super excited to have Dr. Matt host this webinar. I hope you all get the chance to connect with him. He's got a ton of resources to educate and help individuals stay active, take care of their health and mobility, elevate their mindset, and achieve optimal performance. Without further ado, I'll let him get started.
Thank you, Olivia. I appreciate that. Thanks everyone for showing, and thank you for taking the time to taking the time to watch this webinar. I'm hoping that I'll be able to educate you on a few different things today regarding tennis and golfer's elbow. A lot of the studies I'm going to be showing today are related to tennis elbow because that's the more common of the two, but a lot of it does translate over to golfer's elbow as well. And so I just focused on the most common out of the two, but we'll go over each of those. The goal today is really to go and have you help you have an understanding of how tennis and golfer's elbow is treated in a conventional setting versus how it's treated at Ethos with the therapies that we've kind of decided to use for treatment, and how we've developed a strategy for addressing tennis elbow and golfer's elbow. So we're gonna start off by talking about a patient of mine called Mary. And so Mary was someone that I had started, that I chatted with at the end of 2020. So December 2020, got on the phone with her, and she's a tennis player in her 50s, does a lot of competitive leagues here around the Valley. And she had been doing this for several years, had experienced tennis elbow, along with a bunch of other injuries. And ultimately, what led her to contacting me was that she had had this tennis elbow going on for several months. She had been to multiple doctors, and it had yet to resolve. And so she was really looking for someone to help her with that. And we had a discussion about tendinopathy itself and what can be done for that, and the different stages that people go through with it. And so ultimately she decided to come and work with me. So we're going to be kind of following what that discussion looked like. But again, she had significant pain for several months, was unable to play tennis, went to multiple doctors, couldn't get an answer for any of her, for her issue. And really just had to sit on the sidelines because she couldn't enjoy the activity that she loved the most. And so she really missed out on a lot of different competitions, a lot of different things that she wanted to do. It started to affect her grip. She even had trouble like holding her phone, different things like that throughout the day, her water bottle, all that stuff. So that ultimately what can happen is, it can progress to the point where it really impacts your daily life. And so Mary didn't want to continue down that road. And so she called and chatted with us. When she came in, we did our intake, and we looked at her ultrasound, we did an ultrasound on her elbow, and the ultrasound showed moderate lateral epicondylitis or tennis elbow. So when we're looking at a tendon damage, there's mild, moderate, severe is the easy way that we grade it. And so she had moderate to almost severe. And this, this again was brought on by a lot of tennis, different things like that. But it can also be brought on by a number of other common motions that people do. So one of the biggest groups of people that have this issue is actually going to be construction workers from using hammers, different things like that constantly. But we did an ultrasound on Mary. This was the first time she actually had an ultrasound done on her. So she had been to multiple doctors, multiple specialists, and all of them had told her she had the signs of tennis elbow, but no one was ever able to grade it and really tell her specifically what, how bad was it. Oftentimes, the only time that they'll go and doctors will go and order any imaging is if they're working to justify surgery. She hadn't been having pain long enough when she met with these doctors to justify MRI. Which is what most doctors use to do it. An ultrasound is actually the best imaging for evaluating golfers and tennis elbow. And this is something that we offer at our practice. And so it's kind of, this is one of the first steps that we take with people, because I need to know how severe is it, because that's ultimately going to determine what the best treatment is for this patient. And so again, hers was moderate to severe. And so we figured, we saw that on her ultrasound itself. Now, before she came into me, Mary was left asking, will I have to live like this for the rest of my life? Do I have to stop playing tennis for the rest of my life? Is this just part of getting old? We hear that one a lot. And will I ever be able to compete again? Being able to compete in tennis was a big thing for her. And so she was left asking these questions, and we're going to go and discuss what that journey looked like. Now, right before we go and discuss, just a little bit about me for anyone who's not familiar with who I am. I'm a naturopathic physician by training, and I have a special interest in sports medicine. And primarily joint pain. So elbow pain is one of the primary things that I treat. I'm the co-owner of Ethos Integrative Medicine. And then I'm also a host of Ethos Athletes podcast as well. So that podcast is designed to help individuals who want to be active and provides resources for them to learn how to stay active, different things like that. I also train other medical providers in regenerative medicine, and I work with active individuals to help them stay active and enjoy life. I was fortunate to be voted a Phoenix Top Doctor in 2018 and again in 2020. And so, just want to share a little bit about that with me. That way, a little bit more about my background, and we'll continue on with Mary's story. So when we're looking at tennis elbow or golfer's elbow, ultimately this is called a tendinopathy. And tendinopathy basically means it is abnormal tendon tissue. There are multiple phases of tendinopathy, anywhere from inflammation of the tendon itself, all the way to a full rupture of the tendon. And so there's a number of different progressions that you move through as tendinopathy gets worse. Phase 1 is what's called reactive tendinopathy. And what happens in this particular phase, this is actually really normal to occur. So reactive tendinopathy occurs when anytime you work out, lift weights, do things like that, you actually cause tendon damage. That tendon damage is not bad in that phase. Ultimately, what you're doing is you cause these small micro tears in the tendon that anytime you lift weights, do stuff like that, that when the tendon has time to repair itself, then it'll actually go and repair stronger. So it'll make the tendon stronger, more resilient, different things like that. that is a perfect phase of what you want. And anything beyond that, we start to have an issue. But phase 1 is a completely normal process. It's very healthy, and it ultimately leads to better tendon health. Phase 2 is tendon disrepair. The disrepair occurs when you start to have a problem with the tendon not being able to repair in time. So tendon gets used to the point where it gets damaged, just like in phase 1, but you're doing it so frequently. So people that are working out multiple times a week, doing and working on the same tendons every single, multiple times a week, working on the tendons every single time they work out, or a specific tendon every single time they work out. Different things like that. So a tennis player is a great example of this, where let's say they go and practice every day and they go and do the same motions every single day. Ultimately, it leads to specific tendons being injured because they don't have enough time to recover and repair. They don't have any days rest in between. So when that damage becomes more than the repair time, then you have tendon disrepair. This is when we start to have issues. You then move into phase 3, which is degenerative tendinopathy. This is where you start to get fraying of the tendon. So the example I like to use in this case is when people go, if you were to go and take a piece of rope and rub it on a sharp rock, that fraying that occurs on the rope, that's degenerative tendinopathy. That will go in, that fraying will happen to the tendon, and then over time, it ends up leading to tendon tear or rupture. So those are the different phases, and most people start to have an issue in phase 2 plus is when it's pathologic. So ultimately, that's when we need to start going and fixing things. So when we're talking about tennis elbow, the 2 primary tendons involved in tennis elbow are the extensor carpi radialis brevis and extensor digitorum. Ultimately, they all lead to what's known as they all come together into what's called the common extensor tendon, which, if we look here, is going to be this little piece right here. So this tendon, again, the tendon attaches muscle to bone. This common extensor tendon is what's typically found in tennis elbow, to be pathologic. Golfer's elbow involves pronator teres or flexor carpi radialis muscles. So this is going to be on the inside of the elbow, whereas tennis elbow is on the outside of the elbow. This is going to be a problem in golfer's elbow. So again, if we have our elbow here, tennis elbow's out here, golfer's elbow is in here. So how do you know if you have it? The symptoms are actually pretty easy to identify. So it's elbow pain localized to the epicondyle. So again, if you have tennis elbow, it's going to be pain localized right here at the edge. And then if it's golfer's elbow, it's going to be right here on the inside. Typically, people will have pain with wrist flexion and extension. So if you do flexion, extension, that will cause pain at the elbow as well. And then if you're holding a 5-pound weight or anything like that. So if it gets really severe, like people have trouble holding their water bottles, but it can be, very little weight that actually causes the elbow to flare up. Though if you have those are really common signs of tennis or golfer's elbow. And so that's when we'll want to, take a look at having that get checked out. So now we're going to go into what checking it out looks like, and we're going to focus on the conventional model. So there are some good things within the conventional model, and then there's also some problems with it. So I'm going to focus on both, but ultimately the summary is the problems here. And the problems that we have with it is that it tends to band-aid the problem. You have a long downtime because a lot of doctors will go and just basically do a watch and wait. So they say, let's go ahead and, do this therapy, or, put a brace on it, and let's see where it's at in 8 weeks. Let's do this and let's see where it's at in 8 weeks. Different things like that. And so, and then eventually, once you pass so much time, then they'll start doing something about it. So there's a long time due to watch and wait. Once you hit phase 3, so there's some really good things that we can do in phase 2 to go and help, which is the tendon disrepair phase, to go and help improve the tendon repairing. But once you get phase 3 into degenerative tendinopathy, then we really start to have a problem. We have enough tissue damage to where there is tissue that's causing pain. And at that point, we start to have an issue. And in the conventional medicine world, there is no real option for phase 3. It's basically, let's just wait until hopefully it goes away, or until it gets really bad, and then we'll do surgery on it. And so there's really no great option for phase 3. This is where our stuff really shines. And then it can take up to 6+ months to resolve the issue. And a lot of that's due to watch and wait, or they eventually wait long enough to have surgery. And so we'll talk about those things. The very first thing that we're going to be looking at, so we're dissecting the conventional approach here, and the first thing that we're looking at is activity modification. So what this typically looks like is you come in, like in Mary's case, Mary went to the doctor, said, "Hey doc, I'm having really bad elbow pain. It's from tennis elbow." And the doc says, "I agree, it's tennis elbow. Just stop playing tennis for 6 weeks, and then it should go away." And so that's option 1. That's what they do right off the bat. Stop activity for 4 to 6 weeks, and then sometimes 6 to 8 weeks, and then let's see how you respond at that point. And so they usually wait that amount of time, make you stop the activity, and then you can proceed from there. Now, when we're looking at activity modification, there are some good things for this, and ultimately, this goes back to what is your training load. So when you're looking at loading the tendon, the tendon does need time to repair in between. And so you can go and make a really good impact with activity modification if you're in phase 2 or phase 1. And if you did this up ahead of time, you won't get to phase 2. Like if you do really good training loading during phase 1, which a good coach, a good physical therapist, different things like that, a good trainer, they'll know how to do this properly. If you're having someone either coach you or train you through your exercises, they should know how to do this if they're really good. And ultimately, they'll work on your training load to make sure that your common extensor tendon doesn't get worked every single day, and it'll get spaced out properly, stuff like that. So activity modification is a good thing when in order to prevent you from getting to phase 2+. But once you get into like phase 3, it's like, okay, well, is it really going to help you? Like, in most cases, individuals like Mary are coming in when they're phase 3, phase 4, and they're being told to stop playing tennis and just to see what happens. And so activity modification is the best preventative thing that you can do. And it really doesn't have to do with stopping altogether. In that case, it's really just managing the training load. But in most cases, doctors don't really know how to educate on that. And so they just say stop altogether. And so if you have a good coach, a good trainer, good physical therapist, they'll be able to help you through this part. But in Mary's case, she went and stopped playing for 6 weeks, and then they didn't do anything because she's already beyond the point. And this goes back to the diagnosis. They waited too long to do any kind of imaging ultimately on her. And so had they known she was in phase 3, they would have, they may have jumped, a few of these, numbers here in order to start giving her treatment, but they didn't know that because they didn't do imaging in the first place. Step 2 is bracing. So after Mary comes back and tells the doctor, "Hey doc, I stopped playing tennis for 6 weeks and I still have pain. Okay, well, let's go ahead and brace it and let's see how you do with that." And so, she goes and wears a brace. Mary, being the active individual that she is, isn't going to stop really playing a whole lot at this point, because it didn't, stopping didn't do anything. So might as well go play and just kind of suck it up on the pain, and hopefully the brace will work. And in this case, we have this study here. Basically, it showed that there's a lack of evidence for the long-term benefit of braces in this case. And ultimately, what we're interested in here is the fact that the brace doesn't work a whole lot, and it doesn't give a long-term benefit. It only gives a little bit of short-term, which in Mary's case is good. That means she's allowed to continue playing for a little bit longer. But ultimately, it doesn't help too much on this one. So then she comes back to the doc and says, "Hey doc, it's been another 6 weeks. I wore the brace, still have the issue. I even decreased my frequency in playing tennis, but I still have a problem. So what can we do now?" Doc comes back and says, "Okay, well, let's do NSAIDs now." So most people at this point are likely taking ibuprofen on their own, or Tylenol or anything like that. One of the better things that can be done is taking topical diclofenac, which is an anti-inflammatory that you put onto your elbow. When you do that, that'll actually help give some short-term relief for that elbow pain. Again, this isn't a fix. This is just decreasing pain ultimately. And so that's what Mary was given next. It did help. Again, she would use that and the brace and decrease the frequency of tennis, but ultimately she still had it. And keep in mind, she's having it when she plays tennis, but it's also impacting her everyday life. So when she's going and cooking, which she also loves to do, and has a family that she cooks for, when she goes and lifts a pan, she can't do that. When she's chopping, chopping food, stuff like that, she has an issue with that. Drinking a water bottle is painful. So, even though she's limiting tennis, there's still other things that she's doing that are still aggravating it, that she can't really help but stop. And so the diclofenac at least helped her a little bit, but ultimately it's a short-term thing. It's not fixing the problem. She did this for several weeks again, and ultimately, they finally sent her to physical therapy. And so with physical therapy, you'll notice this is the first time my guy doesn't have anything that he's carrying or a brace or anything on him. And that's because physical therapy is actually one of the best things that you can do for this. Oftentimes, what happens is you get to this point, and with physical therapy, if you're seeing a good PT, there's several things that they can do to help decrease the pain and even fix the problem depending on where you're at in the stages. And so for those of you that know me, I work a lot, very closely with several PTs throughout the Valley. And physical therapy is something I'm a huge proponent for. And I usually co-treat with a lot of PTs when it comes to treating joint pain. And the elbow is no different in this case. So one thing I will say, not all PT is created equal. This particular study looked at the effectiveness of physical therapy for tennis elbow. And what you can see in the conclusion, so it says, despite the large number of studies, there's still insufficient evidence for most physiotherapy interventions. There's contradicting results, etc. Ultrasound had weak evidence for efficacy, and much better design conducted reported research is needed. So I wanted to put this in here, and the reason is because when we're looking at physical therapy as a whole, in general, if you are going to, in this case with tennis elbow, if you are going to a PT that is doing ultrasound, e-stim, like all these excessive therapies throughout your session, you may not be getting the best treatment. And the reason for that is because those those may help with mitigate the pain to some degree, but it ultimately, again, doesn't fix the problem. So realistically, it's no different than taking the topical NSAID to decrease pain. And so this is where we focus a lot on really vetting our physical therapist to make sure that that's not happening with our patients. That's why I prefer to my patients go see the PTs that I work with, because I've vetted this part, and I know that they're not going to go and waste time on doing therapies that don't have a whole lot of great evidence behind them. And so that I wanted to put that disclaimer on there for this one. That not all PT is created equal, and this study shows that. Now, the physical therapy that does work extremely well is going to be when we're using isokinetic and eccentric programs. And ultimately, this is particular exercises. I'm not going to get into all this because I'm not a physical therapist at the end of the day. This is their job to do, and this is why I refer to them. But ultimately, the best thing that can be done for tennis elbow and golfer's elbow is doing isokinetic and eccentric exercises. A good physical therapist will focus primarily on this during your sessions. So some PTs, again, not all PTs are created equal. Some PTs will go and give you a go and do all the different treatments that we talked about that don't necessarily help a whole lot, and then after that they'll go and give you 15 minutes 10 minutes of exercises to do, and ultimately that doesn't help you. That's not the biggest benefit for you. So you need to go and primarily focus on these exercises and stretching and different things like that are going to help release tension from the elbow and ultimately help the tendon heal. A good PT will also go and train enough to the point where you can, anytime we train the tendon and work the tendon, it does build collagen in that tendon, which ultimately strengthens it. And that's what we need. We need more collagen to be deposited in there. And so ultimately that's what we're going for with really good PT. I will give a special shout out to Streamline Physical Therapy, who is one of the PT clinics that we work with. They're fantastic. They actually gave us a free book to give to our patients or to give to anyone that watches this webinar, that gives some exercises to do at home that can help decrease pain if you are having an issue with it. And then that at least gives you a starting point to do, and a little bit more to do than just doing a brace and NSAID, stuff like that. Next thing that we're looking at is, so it's funny, the algorithm in conventional medicine says, okay, if physical therapy didn't work, let's say you did it and it didn't help you, so PT was not strong enough to help, then we're just going to go back and repeat all those other therapies again that you just went through, just to see maybe it'll work. I don't know. We'll find out if it works again. And then if it doesn't, then we'll move on to glucocorticoid injections. So I actually thought that was pretty funny. It's actually built into the algorithm of, if PT fails, start over with activity modification, bracing, NSAIDs, and then go to cortisone injection. So it just kind of shows you it's a little bit of waste of time. I just thought it was really funny. So I put that in because, it was literally from the algorithm itself. The next thing here is going to be glucocorticoid injections. And so this is where we do steroid injections. And steroid injections have good benefits to it to some degree, but it usually isn't outweighed by the bad. And so what we're looking at with corticosteroids is, you can see here that on this particular study, it had short-term benefit, but a negative effect in the intermediate term. So once you pass 6 weeks or something, it's actually negatively impacting the tendon. And it actually showed that exercise and stretching had a better short-term and long-term effect than just steroids itself. Now, anytime you go to an orthopedic surgeon, even a primary care doctor, different things like that, one of the things that they'll recommend right off the bat, after they say activity modification, brace, and stuff like that, is going to be doing steroids. And I've seen multiple patients come into my office where you go and they received a steroid, got better for a few weeks, it came back, and then the doctor gave him another steroid, and they repeated that up to 3 times, because every doctor knows that you can't have more than 3 corticosteroids or steroid injections in a year. And so those doctors most of the time will go and do 3 treatments, barring the patient hadn't had any others, into the tendon itself. It's usually done blind, so meaning they just go and put a needle in. They actually don't watch to see, or they don't use an ultrasound to see if it's actually in the tendon. They just go and put it in and hope it's there. And they end up doing 3. And ultimately what it does is it actually damages the tendon over time. So it actually causes cell death in the tendon, and you're already having damaged cells and damaged tissue in there. And so now you're just compounding that problem when you're doing 2-3 treatments. 1 treatment even shows damage. That's why that's why the study pointed that out here. But it can be beneficial in cases where, let's say, Mary had a competition. Fortunately, she didn't. When she came to me, she didn't have a competition coming up that she was planning on competing in. But let's say she came in, was like, "Hey, I have this competition. I need to just be able to do it and then move on from there, and we can work on fixing it after." That's when a steroid would be indicated. Or if the pain's just so severe, that's when it would be indicated. But ultimately, we want to avoid that because again, even just 1 can cause damage. This study here actually went even further and looked at the comparison of steroid injection, physical therapy, and then watch and wait. And what you notice here is success rates at the 52-week mark: 63 or 69% on injections, 91% on physical therapy, and 83% on watch and wait. So watch and wait, meaning they didn't do anything aside from maybe just stop their activity, actually outperformed in the cortisone injection. Whereas you'll notice what I mentioned earlier, at the 6-week mark, cortisone injections did better. It outperformed everything else. So it was 92% successful compared to PT, which was 47, compared to watch and wait, which was 32. So it does help in the short term. In the long term, the pain always comes back, and you have to ultimately still face the problem. Recurrence rate in the injection group was high, as you can see on this slide as well. So it's going to come back, and you're going to have to still go through all the process that you've been going through again. So good for if you need it, and if you need to get out of pain for some specific reason. Outside of that, not the best treatment. And then the last one is surgery, and we'll look at surgery in a second. You'll notice that the little guy here has a brace back on, because once you have surgery, now you're back to bracing, and then you kind of have to go through physical therapy again. So you basically just repeated the loop once you spent all this time getting to surgery. And again, that's where the issue with treating tennis elbow is really a problem, is you have to do all these things only to get back to where you started, and then hopefully feel better after that. Now, the interesting thing with surgery, there are 3 treatments that we look at for surgery itself. So the abstract on this article was far too long for me to go and put it on here as well, but you can go read the abstract or the study if you like. Ultimately, there are 3 different methods when it comes to doing a surgery on tennis elbow or golfer's elbow. The original surgery that was created was an incision cut. So basically, you go and cut or make an incision on the elbow, and then you slice out the damaged tissue that's there. That eventually led to the progression of doing an arthroscopic surgery, where now the incision's much smaller, and you can go and remove the tissue in the same way. And then that led to another development of a surgery that's called Percutaneous Tenotomy, and that basically uses a needle that goes into the into the tendon itself and removes the dead tissue. The reason I put this on there is because all three of those treatment methods actually produce the same results. And this is what this study talks about. Not any one of these treatments was superior to the other. They were all pretty much the same result. Like good outcomes when it's needed overall, but they all produce the same result at the end of the day. And that's going to be important for what we're going to mention later. Also with surgery, the other really important thing, and this is really interesting, when you're doing debridement, which is removing the tendon, the damaged tendon tissue that's there, keep in mind that when you're removing the damaged tendon, it's typically removed by what the doctor can see, whether it's via ultrasound, arthroscopy, whatever it is. It's what the doctor can grossly see. So think about that piece of rope again, and let's pretend that a bunch of those fibers are torn off, like some of the bigger fibers that make up the rope are torn off or torn up quite a bit. Going and removing those big fibers is what the doctor does with the surgery. But this study shows that when you have microscopic tendinopathy, so the cells that make up the tendon still have, and the tendon fibers themselves, or some tendon fibers still have this microscopic damage that actually leads to a poor surgical outcome. And that leads to the patient still having pain after surgery. So that's really important to know for another thing we're going to discuss later. So if you're just removing the obvious tissue that's damaged, you can help the patient to some degree, but if there's still microscopic tendinopathy left over, you're still going to have pain. And so that's an important thing to keep in mind. Now, ultimately, with conventional treatment comparison, these are a few things that we're going to, this is a comparison side by side. All three of these, physical therapy, medication, steroid, surgery, can decrease pain for less than 3 to 6 months. Most of the time, it's going to be less than 3 months with tennis elbow. Decreasing pain for greater than 6 months, physical therapy can do, and so can surgery. That's my fault. This should be a check mark here. That was my fault. Improving function, physical therapy can do, surgery can also do. I made another error. So thus far, surgery and physical therapy are very similar. Removes damaged tissue. Physical therapy does not do that, nor do meds and steroids. Surgery does. Promotes healing. Physical therapy does that. Surgery doesn't do that because you removed everything that you can heal. And then the risk level for everything. So physical therapy is low. Medications are low to moderate, depending on how long you're taking these medications. If you're taking ibuprofen for a year and a half, day in, day out, because you're having significant elbow pain, now you're in the moderate risk category. Steroids are moderate because ultimately you are causing more damage down the road. And then surgery obviously has the high risk level because you're having surgery. So going under anesthesia, being put out, stuff like that, those are things that increase the risk level of what you're having to deal with. So this is the conventional treatment comparison. Now let's recap the problem of the conventional treatment model. So again, it band-aids the problem. There's a long downtime due to watch and wait, and that watch and wait includes activity modification, bracing, NSAIDs, and then they start doing something when it comes to physical therapy. There's really no options for phase 3, which is degenerative tendinopathy. And then this can take 6+ months to resolve the issue. You saw that if you are a surgical candidate, you are not determined a surgical candidate until you are 6 months minimum having this pain. Most of the time, they're actually waiting for a year of you having this pain before they consider you a surgical candidate. And so you probably got your MRI at the 6-month mark if you're lucky. And so to grade what's going on with it. So that's recapping the problem here. Now, what we did at Ethos is we went and looked at, okay, these are what the problems are. How do we go about fixing that? So if we're wanting to find a solution, what if instead of band-aiding the problem, we fix the problem instead? So there's tendon damage. How can we fix the tendon damage? Can we stop the tendon damage from coming back so that, it doesn't repeat itself down the road? Instead of being watch and wait, what if we're proactive about healing? What can we do to help promote healing, either in the early phase, or can we start physical therapy sooner and move forward with that? It really all depends on where they at based on their ultrasound. And that's where the ultrasound is really important, is that it allows us to know where the problem, or how severe the problem is from the very beginning. We don't have to guess on that. What if instead of allowing for degeneration to continue, we can stop it from progressing? And that goes back to being proactive about healing. So this phase 3 aspect, where no one has an answer for, we actually can do stuff for that. And then instead of taking 6+ months to resolve the issue, what if we use newer therapies designed to help you recover quicker? And so we built a plan around that. And again, it all really starts with that ultrasound and really understanding what's going on for that part. And so we'll discuss that here. So our approach to tennis and golfer's elbow, the very first step that we take is understanding your goals. So understanding your goals is important because ultimately we need to know, are you a competitive athlete? Are you someone that relies on your elbow for work? Are you like a construction worker, a chef, different things like that, where you constantly need to be using your elbow and not have any pain? Is it impacting your daily life? Do you just want to get better in your daily life and don't care about ever playing tennis again or playing golf again or different things like that? Everyone has different goals that are unique to them. And so we really need to understand that, because ultimately understanding that part is going to determine what the best route is for treatment. Defining success for us. So this is our definition. We can modify this based on what the patient, on how the patient is. So our success, though, how we define it, is patient is out of pain, their elbow function and range of motion is fully restored. So there's times when they can't go and lift their arm, or they can't even close their elbow or close their arm here because they're in so much pain. So is that function and range of motion fully restored? Is the elbow joint stable? Can the patient safely return to activity? And do we prevent the injury from getting worse? So ultimately, our job is to fix it. But at the end of the day, can we stop it from coming back? And that's something that people who are active, who rely on their elbows day in, day out for either work, play, stuff like that, we need to have that ability where they're confident it's not going to come back. And so with that definition of success, our success rate thus far has been 96%. And so, that's where we currently hold right now. And we're hoping to improve that percentage with one of the new therapies that we brought on, which is going to be one of the ones I'm discussing in a few minutes. So that's how we define success. And ultimately, we go and understand what the patient's goal is. We we line up ours with it, and we move forward from there. And that's how we're able to be successful in helping patients. So once we understand what the goals are and we define what success looks like for that patient, then the next thing for us to do is assess the problem. And when we're looking at assessing the problem, we have a unique approach to elbow pain. And this goes beyond what most providers, what any individual provider looks at. So the things that we're interested in with elbow pain specifically are, or with any joint, but in this case is symmetry. So the very first one is symmetry. This has to do with what is the skeletal alignment, so spinal alignment, shoulder alignment, all these different things on the body. Oftentimes, if a patient has elbow pain, it almost always is related to a shoulder issue. And so or a wrist issue. And so we need to understand, what does symmetry look like? Does the, is the spinal alignment correct when we're looking at, what do you call it, symmetry of the wrist? Do they have the same amount of flexion and extension in both wrists, or is the one that is causing where they have elbow pain, is there a limitation there? Why is there a limitation there? Different things like that. And so we need to understand what symmetry looks like, because that helps us determine what what part of the problem is. The next thing is neuromuscular. Neuromuscular has to do with muscle tightness and also with nerves around the elbow itself. So oftentimes, if we're talking about tennis elbow, again, the pain's right here. One of the muscles that you have on your extensors, which are on the top of your arm here, those can become really tight. If you're someone that constantly uses a mouse throughout the day, or again, a construction worker, different things like that, that can tighten those muscles on your extensors. And when those become tight, it starts to pull the tendon from the bone, which then starts to go and cause pain. So understanding if muscle tightness is a proponent, that's an important piece. There are several nerves, like your radial nerve, that run next to your elbow. When that's inflamed or irritated, that can cause problems with what do you call it, with your elbow as well. And it can irritate the tendon or cause damage to the tendon through pain signaling as well. So those are things that we need to evaluate. Stability primarily goes with, what are the ligaments, and we know that there's likely a tendon problem, but what do the ligaments and the muscle strength around the elbow look like, as well as the shoulder, as well as the wrist. All of these things contribute to stability of the elbow. If there's an issue with the ligaments around the elbow as well, that's going to cause more pathology to the tendon, and so we need to pay attention to that. And then articulation, do you have an issue with arthritis in the elbow? Different things like that. Not super common, but it's something that we still need to screen for, because if you have elbow pain, we don't want to always assume it's tennis elbow. We need to understand what other pieces can it be and can it not be. That way we make sure that we treat the right thing. And so those are four things that we evaluate, or these are four pieces of the puzzle that we looked at evaluating elbow pain, as well as other joints. And so this is really important. And that's why, in phase 2, we're really trying to understand what the problem is and assess it. And then once we determine, okay, once we evaluate all these things, if we still determine, hey, it is a tendon issue, let's go and look at it. Let's use our ultrasound. Then we can go and look at the ultrasound, grade how bad the elbow is, and then we can move forward from there. And so once we assess it with the ultrasound, with our exam, our intake, all those things, we can then select the appropriate therapy. And that therapy kind of skips through, we talked about activity modification, physical therapy, all that stuff. Most of our patients have gone through that already, and they're still not better, which is why they're seeing us now. If they haven't done anything else, then we have that discussion with them. But there's always, let's go and, instead of doing this watch and wait thing, let's be proactive about it. Let's do several things to get you going and getting you better faster. Ultimately, what we're trying to do is saving time on this part. And that's where you can see here, from understanding the goals to selecting the appropriate therapy, that's usually about a week's time. And the only reason it's a week is because the ultrasound is done by a highly trained sonographer that we bring in a few times a month to do those grades and to grade the severity of the issue. But all this is done within a week, and in a week we know this is the route that we're going, this is our game plan, and we should start to see progress within this timeline. So when we're looking at therapies, the goal of the treatment, and I'm gonna, I put this study up because I thought it was really important, just because it can get missed very easily. It says the goal of non-surgical treatment is revascularization and collagen repair of the pathologic tissue. One of the ways that you can do this is through rehabilitative exercise, and that's why, again, I promote PT a lot. But ultimately, if the pathologic tissue is too far gone, so in the event of rehab failure, then surgery may be needed to remove the pathological tissue. Now, ultimately, there are other things to do before surgery and after physical therapy, and that's what we're going to be discussing. So the thing I want you to focus on here is the goal of treatment is revascularization of collagen repair of the pathologic tissue. And how do we do that? So this very first thing that we do is called prolotherapy. Prolotherapy uses dextrose, and in this particular study, used sodium morate, which was well tolerated, and it effectively decreased elbow pain, improved strength in the subjects for tennis elbow. Now, prolotherapy is a treatment where we basically go and use dextrose, which is a sugar. And anytime we go and inject dextrose into a tissue, we're basically telling your body to go and heal that area. So we're causing some micro trauma in that area and telling your body to go heal it. Now, the tendon issue that you have is a micro trauma already, but ultimately, or is a trauma and the tissue's damaged. But ultimately, the healing process stopped, and that's why you're still having pain several months later. So we're basically, with prolotherapy, re-aggravating that tissue to some degree in order to tell it to go heal again and jump-starting that process again. So prolotherapy is something that we can use to help improve that. And it's out of the regenerative medicine treatments that we do, this is the most basic. This is where everything was kind of founded on, is using dextrose, telling your body, hey, bring growth factor to this spot and let's heal it. Now, the next one is called platelet-rich plasma therapy, or PRP therapy. This particular therapy goes and takes your platelets, which contain a high amount of growth factor, and we concentrate it down and we inject it into that site of the damaged tissue. So with prolotherapy, we're telling your body, hey, bring growth factor to this spot. With PRP, we're literally taking that growth factor and putting a high concentration into one spot. And so we can get a higher concentration in one spot than what your body can do on its own naturally. So we're putting that growth factor in there, and we're working on healing and building collagen and revascularization so collagen and blood vessels ultimately into that tendon to help it repair itself. This particular study showed that PRP helps reduce pain, increases function, and it's more effective than a steroid injection. And this part of the study, they went and followed up with patients for 1 year, and a year later, they were still better. So keep in mind, steroid injection is 6 weeks, and then you're back with pain if you're lucky with 6 weeks. Now with PRP, you're at a year later with this particular study. This same group went and then looked at the study again at the 2-year mark, and they found that even at 2 years, follow-up of 2 years here, those same people that they had treated were still improved, like they didn't have any issue. And we found this to be true in our practice as well. Patients I've treated several years ago with PRP for tennis and golfer's elbow are still better to this day. And when that it's nice to see that, and they're still being active. They're doing all those things. So PRP goes and helps with healing the tissue again. This next procedure is going to be what's called a 10X procedure. And we brought this one in. This is the new treatment that we brought in. And we brought this in because of a few patients who did PRP, they did physical therapy, and they still didn't improve. And I had a handful of people that followed that pattern, and I was just as frustrated as they were with them not getting better. So I wanted to find a better, another way to treat it. And for whatever reason, the damage was too far gone, or they just didn't heal appropriately. There were a few different factors with them, depending on the patient, where they went and they got better, but then it came back to some degree. And so ultimately that's not acceptable to me. So we need to go and look at how do we improve that part. And when we looked at their cases, they still had some damage that was still there that didn't repair. So then once they've done PRP, once they've done all this regenerative medicine, what do? If it hasn't fully repaired yet? That's when we do a 10x procedure in this case. So this is for the 4% of people that we hadn't had improvement with just yet, from that 96% that we did. So 10x procedure here is a sonographic guided percutaneous needle. I'm going to show you what that looks like in a second. But ultimately, this study shows that treating it is a safe, effective, viable alternative for patients in whom other non-surgical treatments have failed. So great study here showing how this procedure, how effective this procedure is for that common extensor tendon, and also great for tennis elbow as well. Again, the studies that show both here. This study looked at the 10x procedure or percutaneous tenotomy for tennis elbow that could not improve, and they looked at it after they did the treatment, and then they did a 3-year follow-up. And after that 3 years, all of these patients still had improvement and had not required any further treatment or any surgery. So the stats for this treatment are really high. And then this goes back to the surgery slide that we talked about. So the 10x is percutaneous tenotomy, meaning we go and use a needle to debride the tissue, the damaged tendon. It is as effective as having surgery based on this study. And so this is, the outcomes for it are good when it's indicated. And I just wanted to show that because, again, this study reviewed all 3 methods and determined that all 3 of them were equally effective. So, this is, great because you don't have to go and have surgery. This can be done at an office. You don't have to go to a hospital. No general anesthesia is done. You can do this under local anesthesia, which is how we've done it at our office. And we've gotten good results with it thus far. And so this is, again, has gotten us fantastic results to help that last 4% that we need help with. So what the procedure actually looks like here, you go and make a small incision and you put the 10x needle using an ultrasound. We can see all this. So we're doing all this and seeing it live as we do it. You can see there's healthy tendon and the necrotic tendon. And ultimately what the 10x is going to go and do is go and remove this particular damaged tendon. And so the needle percusses, or the needle retracts at a rate that basically causes ultrasound, and then it's able to go and break up that tissue, and then it aspirates it and removes it out. So that's what the procedure looks like. There's we go and we go and numb the elbow and everything, so you don't feel it. You're sore a little bit after, and that ultimately that's going to happen with any injection. But the procedure is fairly painless because you are numbed in that area. Now, I wanted to look at go back to that article where we talk about lateral epicondylitis and surgery, the arthroscopic debridement, where we remove the large or the obvious muscle fibers, but then you end up having a histologic damage or a microscopic damage to the tendon still. So you go and remove all the tissue that you can see, and then you still have this microscopic tendinopathy that exists. Well, that answer for that is actually PRP. So PRP actually goes and helps change the structure of the damaged tendons, that microscopic tendinopathy that exists. It helps change the structure of that. So if you can go and use a 10X procedure to go and remove the obvious damaged tissue that you can see with your eyes or with the ultrasound, then you can follow it with PRP like 2 weeks later to go and help remove all that microscopic tissue, the microscopic damage that's there. That's going to lead to the best outcome overall, because you don't have that histologic or that microscopic damage that's there anymore. PRP would have helped improve that. So historically, we had gone and done, prolotherapy or PRP for patients. And then the patients that failed, we did 10X. Now, if they have moderate to severe and they meet other criteria where it makes sense, we can just start with 10X, remove that tissue, and then follow it up with PRP to help the remaining healthy tendon with the microscopic damage, if anything, go and heal and help regenerate the rest of that tendon. So that's actually what I think is going to be a better standard going forward compared to what we used to do, plus what conventional medicine does. If we can go and use the ultrasound off the bat, grade it right away, find that it's moderate to severe, we can go do 10X, follow it with PRP, and then have them start physical therapy. And now you're talking about a quicker recovery time. And so I think I believe is the best way to start going from this point forward. When we're looking at how we track everything. So you may wonder, like, okay, where did I get the 96% from, all that stuff? Ultimately, we track progress of all our patients. So I follow up with patients for 2 years minimum after we do their treatments. And that's why I know how everyone has progressed. And so ideally, I see them in person. Sometimes, they move out of state, stuff like that. So I have to do phone calls to check in on them. But ultimately, anytime we're doing any of these treatments, a lot of doctors are very much just like, do the treatment. All right, you're good to go. I'm going to see you in 2 more weeks. If you're still feeling good in 2 weeks, then we're done. And they kind of push you along and move you. I follow all my patients for 2 years minimum, and so if they'll stay with me longer after that, I prefer that, because ultimately knowing their outcomes helps my patients that I help today. But looking at tracking progress for all that's important. And while we're tracking this progress and while we're moving through these therapies, we're also tracking their progress on, okay, we do this treatment, I'm going to have you stop for, we're going to have you stop activity for like a week or 2 just to let the soreness wear off and some of the healing or some of the healing occur. But then after that, I want you to get back on the tennis court. I want you to go back to playing golf and be gentle with it, but let's start to see how those motions when you're doing that sport affect you, because ultimately that's the goal of what we're working on. So I want to make sure that they are improving throughout the process, as opposed to let's do a 10X and a PRP on you, and then I don't really care how you are 6 to 8 weeks down the road, as long as you're good in 2 weeks where you're not having any pain, then I'm going to consider it successful treatment. That's not my stop. I want to make sure that everything lasts and doesn't come back, ultimately, is what I'm going for. And in Mary's case, we did prolotherapy and I believe 1 PRP treatment on her. And, she's continued to, I still follow up with her, all that stuff to make sure it doesn't come back. And then finally, the goal is to return to activity. So this is one of the best feelings in the world that I get with patients, is being able to have them go and compete again, go and do the things that they wanted to do without any issue, and go at it as much as they want. So in Mary's case, she was able to go compete. She was able to level up in tennis, all this other stuff. And, she hasn't had an issue since then. And so that's literally what, best part of my job is being able to see that part. So if we're looking at the comparison for conventional versus ethos, ultimately, what regenerative medicine allows us to do is decrease pain for less than 3 months, because we can usually see that pain go down pretty quickly within a few months. It does last for a long time. Most of our patients have several years of benefit. I think the first elbow I treated was maybe 4 years ago, and that patient still hasn't had it return. So we're looking at pretty good odds with that. Improving function, removing tissue damage. Regenerative medicine can do that now, especially with the 10X procedure. Promoting healing, and then the risk level is low to moderate. I put the moderate in there just because, and anytime we're going and using 10X, there's a little bit more of a risk there than just doing an injection. But even with the 10X, it's designed, the machine is designed to only the sound waves that it creates is designed to remove damaged tissue and leave healthy tissue alone. And so it's extremely safe, all that stuff. And that's why, but I'll still put it as moderate just to, go and respect what it can do. So this is a testimonial. So Marjorie, left us a testimonial for treating her elbow pain, which she also had several other things going on as well. And so, her treatment time took a little bit longer just because I was treating like 3 or 4 things on her. But ultimately her elbow, got better pretty significantly. She had been someone who had been to multiple people. So multiple surgeons, PTs, rheumatologists, all these different things. And ultimately we were able to help her. And she even mentions here that I see her periodically to track everything. So, we're happy to help people like Marjorie, Mary, different things like that. And so, we've been very fortunate to be able to help them. If you are interested, if you can benefit from the approach, you can schedule a free 15-minute consult. I'm happy to chat with you, kind of go over, what you've been experiencing and really understand what your goals are, and then determine, does it make sense for us to work together so I'm able to help you, or if I still think you're early on, like maybe you're not a candidate, then I'll recommend a PT for you, different things like that. And, we can go and start that process and helping you get better. Olivia, I think that is all the things that I have.
Awesome. Well, thank you, Dr. Matt, for hosting this webinar. Super eye-opening to learn about this process that conventional medicine follows and how regenerative medicine differs in that treatment and timeline. And thank you to everyone for joining us today. We'll take a few minutes to answer any general questions. If you have any, definitely type them into the chat and we'll answer those for you. Also just want to point out again, as Dr. Matt mentioned at the beginning, he's the host of a really awesome podcast, Ethos Athletes Podcast. And I linked that into the chat below. So if you liked what you learned about today, I highly recommend checking out the podcast. He's got a ton of different topics, and if you're looking for a specific topic, you can always reach out to me, and I can find that for you as well and send it over to you. And I hope you learned something new about tennis elbow and the research behind these different treatment strategies. If you take anything away from tonight, I hope you understand that if you are experiencing pain, you don't have to live with it forever. There is always a physician out there who will take the time to understand your situation and work with you to create a solid treatment plan that's best for you and your lifestyle. Again, if you have specific questions about your personal care, I highly recommend scheduling a free 15-minute consultation. And then that way, Dr. Matt can go over what treatment strategies may be best for you, or if you need to do PT or that kind of route. We did have a question pop up here, so thank you for submitting that. Question is PT needed after PRP? Yeah, that's a great question. So the answer to that would be yes. And if you haven't, sometimes I get people who have done PT before they came to me. So usually if they've done that, if they saw a really good PT, then the PT would have done all the things that they can to do to help improve the tendon.
And if I end up doing PRP, I usually send back just so they can do a few exercises to go and help the tendon heal and strengthen again, and go through that phase 1 reaction. But it's usually not going to be as involved as if the patient came to me first, and then I'll go and do PRP, and then, you know, at that point, I'll send them to physical therapy, in which case they'll have to go and start all the stuff up again, and then or go and start everything from looking at the wrist to the shoulder, all that stuff. So I think it's a safe bet that you're going to need PT after PRP, just because, at the very least, to help make the tendon stronger with specific exercises.
Awesome. Well, that was a super great question. So thank you, Mike, for asking away. If you have any other ones, anyone else in the chat, definitely type them below. Also want to point out, if you were interested in that free book from Streamline PT, you can reach out to us. I'm happy to share that information with you. We've got a lot of really great resources. So thank you again to Streamline for sharing that with us. And that's all we had for tonight's webinar. So I hope to hear from you, connect with you soon, and hope you have a great rest of your week and a fabulous weekend, and stay warm and cozy. Today was a little bit rainy, so thank you, everyone.
Awesome. Thank you all for joining us, and thank you, Olivia, for hosting it. I appreciate it.